Hello, and welcome to our informal debate on the standardization of evidence-based treatment as an ethical necessity. My name is Alex Stanfill, and I will be acting as the group introducer, summarizer, researcher, and illustrator of claims in support of the standardization of evidence-based treatments. Emily Ritzma will be acting as a summarizer, researcher, and illustrator for additional claims in support of the standardization of evidence-based treatments. And Hannah Vollenwalder will be acting as a summarizer, researcher, and illustrator for claims in support of the standardization of EBT, and will also be providing counter-arguments to the group's position. All members acted as fielders for this assignment. So the diagnosis of autism spectrum disorder has been increasing for decades. According to Stalmer, special education enrollment for children with autism in the United States has quadrupled since 2000. This, along with the fact that ABA is already a relatively new treatment for ASD, has resulted in improper treatment and interventions being carried out on individuals with ASD due to the shortage of effective ABA services and treatments available to help reduce the symptoms and characteristics of ASD. So, horrific abuse and maltreatment of individuals at the hand of professionals belonging to the field of ABA during the 1970s highlights just how far ABA has come in a very short amount of time. One popular example is the Sunland Training Center in Miami, Florida, and this exemplifies what non-evidence-based practices can lead to. In 1972, the professional leading the center, Dr. E, established treatment programs that included forced public masturbation, forced public sex acts, forced washing of the mouth with soap, beatings with paddles, and excessive use of restraints, according to Bailey and Birch. And what resulted from the investigations into the treatment center fueled the development of what we know today as the Professional and Ethical Compliance Code for Behavior Analysts. The internet has enabled the spread of easily accessible misinformation regarding treatments and cures for the ASD community. Many of the techniques that parents use have no empirical support, they're expensive, they take up valuable time, and they can be very dangerous. Boucher states that many untested cures for autism are made in entirely good faith, while others are developed by individuals seeking to exploit the ASD community in order to profit off of desperate parents through the selling of treatments and cures that hold no scientific merit. Some of these treatments include a $300 book claiming to defeat the autism in your child. Others include stem cell injections, bleach ingestion, bleach baths, and chelation therapies that claim to cleanse metals from the body via sprays and also suppositories. This greatly contributed to the group's decision to argue in favor of a standard of care that demands evidence-based procedures. And we believe that it's not only ethical, it's a necessity in order to uphold the integrity of the field of applied behavior analysis. The mass amount of false advertising and misinformation concerning treatments and cures for ASD is a significant threat to all individuals in our society. There is an obvious need to distinguish between evidence-based and non-evidence-based interventions, and this is what prompted the National Autism Center to design the National Standards Project. This project publishes what is called a National Standards Report, and this gives educators, parents, practitioners, organizations the information that they need in order to make informed choices about effective interventions for individuals with autism spectrum disorder. Phase 1 was published in 2009, and it included interventions for people 22 and under. In Phase 2, that was published in 2015, it updated the Phase 1 literature, and then it added interventions for people that are 22 and older that also have an ASD. which there's not very many resources for that. And what's really exciting is phase 3 is set to be published in 2021, and it's going to include research conducted through the year 2018. And currently there are 14 evidence-based procedures and 18 emerging treatments listed in the National Standards Report. And these treatments demonstrate effectiveness, but for the emerging treatments, they demonstrate effectiveness. There's just not enough evidence to list them as evidence-based procedures. According to Cooper, Heron, and Heward, an individual has a right to a therapeutic environment, services whose overriding goal is personal welfare, treatment by a competent behavior analyst, programs that teach functional skills, behavioral assessment and ongoing evaluation, and the most effective treatment procedures available. Code 2.9A of the BACB Ethics Code states that clients have a right to effective treatment based on literature and adapted to the individual client. Behavior analysts always have an obligation to advocate for and educate the client about scientifically supported, most effective treatment options and procedures. Effective treatment procedures have been validated as having both long-term and short-term benefits to clients in society. And according to Bailey and Birch, the establishment of an individual's right to effective treatment protects the welfare of the clients as they have a right to be treated with the most effective treatments available. We argue that a standardized approach to the treatment of ASD would improve individual outcomes and reduce potential harm to clients through the use of non-evidence-based interventions. And further, we believe that when evidence-based procedures are taken and adapted to the individual client, we are adhering to Code 4.03, which states that behavior analysts must tailor behavior change programs to the unique behaviors, environmental variables, assessment results, and goals of each client. According to Stalmer, the diagnosis of autism spectrum disorder has quadrupled in the past 20 years, and with the rise of individuals being diagnosed with ASD, we argue that this has created a concern for our society because there is a growing subpopulation of individuals with ASD entering into a community where there is little to no support for them in terms of finding evidence-based treatments. The standardization of evidence-based treatments in ABA for individuals with autism can ensure that financial resources are being reserved for the most effective, socially valid, and evidence-based practices at community and individual levels. From a political point of view, we argue that both local and federal governments should adopt national standards of practice for the field of ABA when providing treatment interventions to the ASD community. We argue that when evidence-based procedures become publicized and used effectively, this will enable our society to shape public policy concerning ASD and its intervention through the development and dissemination of national standards of practice. National standards of evidence-based practices would also help to ensure that individuals living in our country have equal access to effective treatments. And what you see on the screen there is that in 2015, researchers estimated that annual national cost for caring for people with autism would rise from $268 billion to $461 billion by 2025. In the absence of more effective interventions and lifelong supports.
Hi, I'm Emily, and I'll be talking about professional and ethical dilemmas. According to Code 2.09A of the Behavior Analyst Certification Board's Ethical Compliance Code on Treatment and Intervention Efficacy, it states that every client has the right to effective treatments. Those treatments are based on research literature, as well as having adaptations made that fit the needs and behaviors of that client. In addition, the BCBA Task List 5 explains that practitioners must use the best available practices. Smith points out that research must demonstrate that an intervention produces or contributes to producing the socially important outcomes that would cause a consumer to say that the problem is solved. We argue that practitioners must provide treatment that is shown to have a positive impact on the child's life and help them to solve a problem that would otherwise go unsolved. Ethically, practitioners should only use evidence-based practices, but that is not always available, and where there's the best practice available comes into play. A counter argument for this would be that evidence-based community standards affect scientific freedom and can frame the use of punishment or the use of aversiveness as unethical, when in fact, if done correctly, it can be carried out in ethical ways that can greatly benefit the individual.
I'm Hannah, and I'm going to be talking about evidence-based and non-evidence-based. So Code 2.09 states that clients have the right to an effective treatment based on research, literature, and then adapted to the individual needs of the client. There are many reasons this code should be implemented. One, it provides a clear way to measure and practice these treatments. If there is no clear way, then practitioners would all get different outcomes and no one would be able to verify the methods that are effective across clients. The evidence-based practice of applied behavioral analysis states that the structure recognizes the need for clear and explicit understanding of the strengths and evidence supporting intervention options, the importance of contextual factors, including the client's values that contribute to decision-making, and the key role of clinical expertise in the conceptualization, intervention, and evaluation of these cases. The evidence-based practice of applied behavioral analysis explains the primary problem with the LIST approach being that it does not provide a strong framework that directs practitioners to include the best available evidence in all of their professional decision-making. The article also explains that practitioners can also have a hard time finding interventions relevant to the specific case they are working on, or that they have not been validated as evidence-based.
One of the biggest issues distinguishing between approaches and strategies is the definition as to what evidence-based practice, or EBP, really is. Quigley, Broadhead, and Cox gave the example of a three-legged stool, that each of the stool needs to have the same length and strength to support EBPs. Each leg is characterized by what EBP is: the best available evidence, clinical expertise, and client values, preferences, and characteristics and circumstances. Applied Behavior Analysis, or ABA, was first described in 1968, and since then has been making strides with interventions within the educational, behavioral, and psychological fields. There is a strong need for interventions to help clients change their behaviors to being less disruptive. The problem of broad social impact must be solved by having interventions implemented effectively in social important settings and at scales of social importance, as stated by Slocum. As stated before, the definition is a big priority when it comes to deciding if something is being followed correctly. Each person has their own definition of a word, and to assume everyone has the same would be counterproductive. According to the American Psychological Association, EBP is the best available research with clinical expertise in the context of patient characteristics, cultures, and preferences. Within the field of behavior analysis, there is a gap between known research and the implementation in the field. This gap has been presented since the 1960s, where the medical field staff had an even wider gap between the research available and the implementation of interventions. There's an estimated range of 10 to 25% that in the 60s, medical decisions were made based on evidence. Many professionals have used EBP framework to guide how they approach interventions and make informed decisions that benefit the client. The Individuals with Disabilities Education Improvement Act went along with the EBP movement and sent out a memo that stated we should act with strong supporting evidence, consider suggestive evidence, and research more on the weak evidence when it comes to EBPs. In summary, EBP is the best intervention chosen for a client based off the use of the best available evidence that supports the intervention. Using the best available evidence to select intervention also follows along with Behavior Analyst Certification Board guidelines, following 1.01, reliance on scientific knowledge, and 2.10, treatment efficacy, to determine the quality of evidence. It needs to be relevant and have certainty. Taking suggestive evidence as strong evidence, the best approach to EBP is one that has available evidence to support the intervention. When applied behavior analyst was first described in the 1960s, 75 to 90% of interventions were made without any backing evidence. Many professionals have taken the framework of EBP and use that as a guide to how they approach interventions today, which can sometimes muddy up the intervention of an EBP or not.
So there are some limitations of the current research, one being the mandatory treatments, complexity, and time. When dealing with individuals who are unable to advocate for themselves, choosing interventions for them when they don't have a way to choose for themselves is in itself unethical. Dawson has said people with differences have been ostracized to then forced into mandatory treatments for their own good. An example of this is changing a child's writing hand from left-handed to right-handed, using behavior modification to try to make boys with feminine characteristics behave like typical males do. Stammer also explains that one major challenge to implementing evidence-based practices for children with autism community setting is the complexity of these practices. Ballas and Boren have also said that limitations of current research come from the fact that for a practice to be considered evidence-based, it has to be studied for 17 years. Since there is such a large gap in starting a theory from it actually becoming a practice takes a lot of time. The pro side of this is being that if it is considered evidence-based, that means it is proven over time to be effective for different individuals. The process of evidence-based practices becoming evidence-based practices in ABA. Definitions of evidence-based practices differ among professionals. We adopted this definition cited in the Broadhead text by Schlocholm and colleagues, as it incorporates the three-legged stool analogy of spring and stresses evidence-based practices as a process. This process, as explained in Broadhead, Cox, and Quigley, requires that three main components of evidence-based practices: research, evidence, clinical expertise, clinical considerations, must be utilized together to make a clinical decision. Then you can move to designing the intervention, implementing and evaluating the data to see if any revisions to design or the way it is implemented needs to be changed. The graph above demonstrates the order of making practices evidence-based, which includes having research evidence, clinical expertise, and clinical considerations before moving on to intervention design, then intervention and implementation, and then evaluation of the intervention.
So here we have the three-legged stool analogy. One of the issues is the definition of what EBP really is. Quigley, Broadhead, and Cox gave the example of the three-legged stool, that each leg of the stool needs to be the same length and strength to support EBPs. Each leg is characterized by what EBP is, the best available evidence, clinical expertise, and the client values, preferences, characteristics, and circumstances. PBIS, Positive Behavior Interventions and Support, is a program that is not an EBP, but appears to be one. It has all three components of what defines EBP, but one leg is shorter than the other. While PBIS is evidence-based and uses the expertise of those in the field, it is not client-based, but rather school-based. It focuses on ways to support everyone in the school, not just one specific client. What works for some students may not work for others, thus shortening a leg and making PBIS unstable to be considered EBP.
I am now going to talk about some counter-arguments. Dawson argues that standards are developed by and for communities of non-autistics. He explains that community standards are not designed for the ASD community and that peer review amongst behavior analysis has never resulted in respect for the rights of autistic and human rights committee proposed by others, but instead imposes community standards on the individuals who are atypical to most members of the community. Evidence-based practice of ABA explains more that there are a number of reasons why a list of interventions is not an adequate basis for EBP and ABA. These reasons include that practices must be based on a manual. Many consumers cannot be well served with existing multi-component packages. It severely limits the way in which research findings are used by practitioners. This argues against the idea that all practitioners should be evidence-based. Some could also argue that 17 years for a treatment to be considered evidence-based is too slow. That while this is being studied, it could be very beneficial for people all around who would have benefited from that practice. But because it is not evidence-based, it won't be practiced. Saxby and Painter explain that there are 20-year lag between the development of evidence-based practices and its integration. As an introduction to the knowledge to action strategy framework for this disassembling evidence-based practice in autism spectrum disorder, early intervention centers, and its reliance on the National Disability Insurance Scheme, explain that this highlights a vital role of the field of implementation science. And we argue that the knowledge to action framework, which is used for facilitating the use of research knowledge by several stakeholders, such as practitioners, policymakers, patients, and the public, may be applied within the field to ASD patients' early intervention in order to reduce this lag. So the process in early intervention ASD research will be put into action without undue delay. And the benefits of scientific research can be realized sooner, improving the interventions used with children with ASD and supporting optimal long-term outcomes. We are now at our question and answer segment. The first question is, what is the ethical responsibility of BCBAs in terms of ensuring the use of evidence-based treatments? Our answer includes that Code 1.01 states that behavior analysts rely on professionally derived knowledge based on science and behavior analysis, which making scientific or professional judgments in human service provisions or when engaging in scholarly or professional endeavors emphasizes the importance of basing all decisions on science. Furthermore, behavior analysts have an ethical duty to the clients to provide ethical treatment to clients according to 2.09, treatment intervention efficacy.
Question 2. How does a BCBA advocate
So question 2 is, how does a BCBA advocate
for the importance of analysts put the Code 2.04D states that behavior analysts put their client's care above all others and should be the third party make requirements for services that are contradicted by the behavior analyst's recommendations. Behavior analysts are obligated to resolve such conflicts in the best interest of the client.
And question number 3 is, how does a practitioner manage the situation where a parent is requesting that the BCBA implement non-evidence-based procedures? And this kind of ties into a personal experience that I've had working under a BCBA as an RBT with a client whose mother insisted on the really popular compression vest as a form of sensory input for the child. And what had happened was the mom swore up and down that when he would wear the vest, his behaviors would be reduced in the afternoons and he'd be able to take a nap. While the BCBA knew that it wasn't ABA to be using the vest and that we didn't have any sort of evidence base to be using it, she really wanted to meet the parent in the middle. And so they came to an agreement, which is listed in the Bailey and Birch text as one of the ways that you can get out of it is to talk with the parents and let them know, like, hey, we can do this for a little bit. And what we did was we put a condition line in the behavior graph so that we knew what had changed before and after. So we would be able to show the parents if the vest was actually reducing some of the challenging behaviors. And through its use, the BCBA just wanted to make sure that since the client did not really like to wear the vest, that as long as we weren't inducing stress on the child with the vest, it would be okay for us to let the child wear it as long as it wasn't doing any harm or increasing behaviors. And this is the end of our presentation. Thank you, guys.